welcome to our next in our vlog series. I'm delighted to be joined by my friend and colleague, Dennis Butts from beautiful Akron, Ohio. Dennis, welcome.
And thanks, Harry. Glad to be here today.
Yeah. So before we dive into it, tell us a little bit about, very quickly about your career and sort of how you got where you are.
I have been in healthcare, Harry, as you know, for the past 20 years and currently serve as the lead for Guidehouse's strategy and innovation service offering within our health sector. So stretching apart across our payer provider division, public health, as well as life sciences. I actually started my career in pharmaceuticals with Pfizer. So all that's going on with the vaccine is kind of close to my heart. I see what Pfizer has done over time. Went back and got my MBA from Case Western and started as a senior consultant at a small boutique firm directly after grad school, and worked my way from senior consultant to senior manager, came over to Navient, now a part of the Guidehouse team.
Fantastic. Well, great to have you with us. So, we can't talk about anything without talking about COVID. So let's talk for a minute about, we had all of these health systems and other healthcare organizations with strategies pre-COVID, and then all of a sudden things blew up. What did people do? Did they totally throw out their strategic plans and just get their heads down, or who's been carrying through?
Yeah, it's been interesting, and COVID certainly exposed a lot regarding healthcare strategies. It really exposed that we didn't necessarily have the infrastructure in place and the ambulatory assets that when a pandemic hits like this, that we still have the ability to have continuity of care. It also exposed the payment model. When all of healthcare right now is primarily paid on seeing patients of fee for service, that not having a model of keeping patients well and away from the system really exposed the financial condition. It also exposed just the overall low margin business, which healthcare is, until there's thin margins. And so take out the profitable cases and open up shop for a pandemic for the needed response. And it really strained healthcare assets. And as we're thinking about just the pathway moving forward, getting back to pre-COVID volumes, there's a lot of disruption that's happening right now, and it's exposed that our health systems aren't in a financial really position to compete against a lot of the disruptors. And so a lot of our clients now are thinking about what is the refresh of the strategy? How do we compete in new ways? And how do we continue to be a big community asset in the time of need? And so that's a lot of the conversation that's happening right now.
Yeah, and I guess COVID also exposed, as you mentioned, the sort of lack of agility among many of these organizations, where you had certain parts of the organization just absolutely, overwhelmed. And meanwhile, other parts, they were in many places were actually laying off or furloughing employees.
Yeah, when you think about typically a stable industry funded by bonds and long runways and cycles regarding the overall strategic plans, you may be able to do something looking out 5 years or 10 years as we think about facility plans and bed towers, and the agility that you mentioned of how do we not only create plans, but be in a continuous planning cycle of what do the next 6 months look like? How do we continue to respond and really react to the things that are happening in our markets? And so planning at a new pace when there's thin margins and big decisions to be made, where the success or failure of a community asset really falls within what we're going to do over the next few months and few days. It's really pressing leadership teams to be more agile with new thinking and also with new competitors to bring about new strategies for success.
Yeah, I think, one of the interesting things, you talked about, people having a day-to-day strategy, but there have been some elements in healthcare that actually have been going on for quite some time, like the transition to value. And, where are we in that journey now? Did COVID pause this or accelerate it?
Yeah, it's a good question, and there are a lot of conflicting data points as we sit here in the beginning of 2021. The major value-based model, the Medicare Shared Savings Program, is down in membership. I think we're down to around 477 ACOs, which is down from around the mid 500s just a few years ago. And so if you look at pure membership, you would maybe say that the model or move towards value is slowing. But at the same time, if you look at 2019, it was the biggest year of savings for the government. We have around 11.2 million Medicare beneficiaries who are covered by the ACO model, and Medicare actually saved CMS $2.6 billion. And so if you net out the savings, that was $1.2 billion for the government. So while membership is going down, the impact of the ACO model is actually going up. So there's a lot of conflict as you look at things like the next gen ACO model that was supposed to sunset because of the pandemic. It's been extended a year. New programs like direct contracting, should we be in it or not? So what we're seeing is that the move to value is continuing for several reasons. Employers are the biggest purchasers of healthcare. And as we look at continued double-digit growth and overall spend for beneficiary coverage, that's not sustainable. And when you overlay price transparency you see in the news, depending upon what state you might be in or within a state, what you pay for certain services varies widely. And so we don't have a cost of care issue, we have a pricing issue in this country as well. And so the innovation that we're seeing in the employer space, the need to curb overall spend at the federal government level, there's a commitment that the move to value not only needs to continue to happen, but it needs to expand even to state governments with Medicaid. We have an issue where state governments can't continue to afford Medicaid coverage. The economy has a downturn has actually increased the level of beneficiaries on the Medicaid side. So regardless of line of business, commercial, Medicare, Medicaid, the move to value will continue to play out. The question is, what are health systems going to do while you still are paid fee for service to sustainably move to a different revenue model? And that's a lot of the conversations we're having with clients today.
And Des, one of the hallmarks of value-based care is ensuring you have adequate preventive care. And there's a terrifying headline of like, what happens when people stop going to the doctor? We're about to find out. And what's going to happen with all of this pent-up demand of people who've deferred care and deferred procedures? How's that going to impact many of these models?
Yeah, it's interesting because there's been a lot of conversations, even historically, about the accuracy of the benchmark. If you are already in a low-cost environment, how can you win in shared savings if you're starting already at a lower cost point? Areas like Texas that have a big spend, is it actually easier for them to succeed because they're actually having starting from a more disadvantaged position? So those are all the things that need to get worked out to make sure that this is a sustainable model. You're never going to lower the total cost of care down to a $0 effect. So what are the things that we can do that makes it more sustainable regardless of your starting point? So that's a lot of the pause that some organizations have regarding, is this the right model for us? How do we do this and battle or balance the economic impacts of how we might move forward? And so that's a significant decision. But at the end of the day, more of our Americans need higher quality care. We need more outcomes, more value for the dollar that we're spending. And so the challenge is really up to us in healthcare to figure out what that looks like, and then also produce models that are going to be more sustainable moving forward.
Yeah, so Dennis, I did something this morning that would have been unthinkable pre-pandemic. I got up early and exercised. So what are some some of the new things that health systems are thinking about that they really hadn't thought about before that they might do quite differently?
Yeah, I would say a lot of the conversation now is how do we best use data? So not just retrospective data, but how can we use predictive analytics to not just care for patients when they arrive at the clinic or arrive at with an admission or preventing a readmission, but what can we do to make sure that simple things that we can maybe address? So you mentioned preventive medicine. How do we make sure that we're closing gaps in care? How do we identify those who are most at risk to be non-compliant with medication or not really opt into the care management program, so that we can do a better job of preventing disease versus being set up in a way to actually care for patients when they arrive at our clinics? So big data, and not only data, but analytics, artificial intelligence, machine learning. How can we use those big data tools to make sure that we can provide better care? Also, just establishing a better networks. And so there's been a lot of rise in CIN development, ACO development over time, but it's not just the size of your network, it's really the cohesion of your network. And so organizations are working through how do we better coordinate care within established networks throughout our community, not just with providers of care, but as we think about social determinants of health, who's actually at risk, not just from a medical perspective, but what are some of the other things that are impacting outcomes? And let's build that into our predictive models, and then also build that into the solutions that we're bringing to our communities. And so that lastly kind of builds the case for health equity. So there's a lot of conversations that are going on around health equity to make sure that as we think about interventions, how do we cover an entire geography for those who are most at risk? So as we're building care models, that is most likely to get to those who are in need. So those are a lot of conversations of things that we might do different, that not just about care management, care transitions, but how do we best predict who's going to be at risk of healthcare spend? And then what's the totality of the solution that we can bring through a defined network to make sure that we're impacting the population positively?
Yeah, and Dennis, you raised the issue of health equity. And we've seen in COVID equity issues arising, really, the full spectrum, from those who are most at risk to those most likely to have bad outcomes, all the way now to who's sort of willing or to get a vaccine. So health equity, both with the new administration and in what we've seen with COVID, has really come to the forefront.
Yeah, and it's interesting. I mean, we're obviously at the recording this in Black History Month, and so being a Black male, health equity is something that's near and dear to my heart. And just even as I think about the community and personally having lost family members to COVID, which probably could have been maybe prevented if we would be, as a people, utilizing the healthcare system differently. And when you think about things that have happened over time that maybe make people of color suspicious of the healthcare system, that even when we have something that is a solution like the vaccine, can I actually trust the system that this is something that's good for me? And so there's a lot to be said around health equity. I think that COVID, when you just look at the differences in mortality rates and the significant impact of the disease, that it varies based on color lines, varies based on economic status. And that's something that as health systems are looking to not only be a center of care, but a center of health in communities, now that we're seeing that in the data, now what do we do to address it? And I think that community leaders, connection with health systems to get the message out so that we can not only advocate for the best possible therapies, but also advocate for a level of trust in community so that those who need the most care, that they have a trust in the community or the health system. But then also, as we think about other vulnerable populations, what are the things that we can do to bring care to them? Not necessarily come to the big box of where we are as a health system, but are there things that we can do in the community through partnerships to then get care to those who are in need?
Dennis, terrific, and great point to raise. So thank you very much for joining me. It's been a fascinating discussion, and look forward to actually getting back together with you in person when we're able to.
Yes, absolutely, Harry. So thanks for having me, and have a great day.
Great, you too.